Hi everyone, welcome back. In this video, I'm going to talk about a set of conditions known as the hereditary hyperbilirubinemias. All right, so let's start with an overview of the hereditary hyperbilirubinemias. A lot of it is in the name right here. So let's talk about the similarities. How are these four conditions similar to each other? Why are they grouped together? Well, number one, as you can suggest from the name, is hereditary, so they're all inherited and they're all autosomal recessive. And number two, they are all going to have increased in the serum total bilirubin. Again, that is suggested by the name. These are diseases that are hyperbilirubinemias. And interestingly, in most of these conditions, the other LFTs are often normal. Now, this isn't typically the case when you see a condition in clinical practice. Usually when the bilirubin is elevated, this is caused by some kind of a damage to the liver, and so usually the other LFTs are high as well. So if you see a test question where only the total serum bilirubin is elevated, you should start to raise your awareness that they may be talking about one of these conditions right here. Now, the differences between them is number one, the clinical features and severity, depending on the underlying defect in which condition we're talking about. It can be from mild or asymptomatic all the way to severe and life-threatening. And second, one of the main differences is going to be which type of bilirubin is elevated. Is it indirect or direct? And this is one of the ways that you're going to be able to tell them apart, as you shall see shortly. All right, and so let's start with that last part, because a good way to be able to distinguish these diseases from each other as a starting point is to figure out which type of bilirubin is predominant. So this is a screenshot from the video on diagnostic algorithm of jaundice. This is where I talk about when you have a patient who comes in with jaundice, you can break down the causes based on which type of bilirubin is predominant. And so if you take a look right here in the indirect bilirubin category, we have two of these diseases, Gilbert and Crigler-Najjar. Everything else is grayed out. And then if you look over here on the other side where you have primarily direct bilirubin elevation, you see that the other two are listed right here, Dubin-Johnson and Rotor. So based on this, you can see that two of the four conditions are primarily associated with high levels of indirect, aka unconjugated bilirubin, and the other two are associated with high levels of direct, aka conjugated bilirubin. So what we're going to do is first go through these conditions that are associated with high indirect bilirubin. All right, so starting with hereditary hyperbilirubinemias with high indirect bilirubin. First one is Gilbert syndrome. This is the most common from all of these conditions. This is actually very common in the population. About 10% of people in the population have this, and thankfully it's the most benign. The reason for this is a mutation in the UGT1A1 gene, and this is the gene that encodes the UGT enzyme. So here's the little important review or recap of bilirubin metabolism. UGT enzyme operates inside of the hepatocytes, and it's important for conjugation of unconjugated bilirubin to conjugated bilirubin by adding glucuronic acid to it. So in these patients, there's a decrease in UGT activity, and this decrease is mild. So this is going to lead to a mild elevation in the levels of indirect bilirubin. So that means that you're going to have some impairment of the ability to conjugate unconjugated bilirubin. Therefore, the levels of unconjugated bilirubin in the circulation are going to remain high. Now, this usually does not present until adolescence, and the reason that this is thought to be the case is because sex hormones alter bilirubin metabolism, and therefore that leads to this becoming clinically apparent, so it's not apparent early on during childhood, for example. The main symptoms here are going to be no symptoms at baseline, and that's because the high yield and important thing about this condition is that the impairment of UGT activity is mild. Because it's mild, there's still enough UGT activity to deal with the baseline levels of unconjugated bilirubin, so this is not going to present with any kind of jaundice or symptoms at baseline. But what happens is that when you undergo an episode of stress, such as fasting, trauma, exertion, or infection, this is going to lead to excess red blood cell breakdown. So now you're going to have higher levels of unconjugated bilirubin, so a higher load being presented to these hepatocytes. And now this limited UGT activity is not enough to keep up anymore. So this is going to lead to a mild elevation in bilirubin. So these patients are going to have a mild jaundice. But once whatever the symptoms that you were having here resolves and you go back to baseline, the jaundice is going to go away again. Therefore, this is transient. So the key features with Gilbert is that the decreased UGT activity is mild. Therefore, no symptoms at baseline. Episodes of stress leads to a mild and transient jaundice that usually self-resolves when the stress-inducing episode goes away. Therefore, the treatment here is nothing specific, only supportive treatment to treat the underlying stress that caused this exacerbation. All right, let's move on to the second condition that causes high levels of indirect bilirubin, which is Crigler-Najjar. So this is a mutation in the same gene as we saw in Gilbert. Therefore, this is also going to lead to a decrease or impairment of UGT activity. And again, this is going to lead to high levels of indirect bilirubin, just like Gilbert, because it's the same enzyme that's becoming deficient. However, here the bilirubin levels are going to be much higher. The onset is going to be at birth, so during infancy, and the bilirubin elevation is going to be persistent. So this is totally different or more severe than we saw in Gilbert syndrome, and the reason is because the impairment of the UGT activity is much more significant. So in Gilbert, we only had a mild impairment. Here we have a pretty severe impairment of UGT activity. Therefore, we have higher levels of bilirubin accumulating, earlier onset, and rather than transient, we have persistent bili elevation. Thankfully, this is much more rare, and there are two types of Crigler-Najjar, and these are depending on the disease severity. So in type 1, this is the much more severe form. You essentially have complete absence of UGT activity. Therefore, this is going to lead to severely high levels of indirect bilirubin, up to greater than 20 milligrams per deciliter. So this is super high. And the clinical feature here is severe. This is going to cause kernicterus, because when you have super high levels of indirect bilirubin, this is going to happen in infancy, and these high levels are going to cross the blood-brain barrier because indirect or unconjugated bilirubin is lipid soluble. It's going to deposit in the brain. It's going to cause seizures and severe neurological manifestations. It's going to lead to kernicterus. So the treatment here is going to be daily phototherapy to try to get rid of some of this indirect bilirubin, plasmapheresis to try to remove the indirect bilirubin again, and ultimately liver transplantation to try to replace these with cells that have the UGT activity. Now, type 2 is a little less severe, so this one has decreased UGT activity, not absent, and therefore you're going to have mild to moderate levels of indirect bilirubin, so up to 8 to 20 milligrams per deciliter. So the clinical features are going to range here, but generally it's going to be milder than type 1, and in this case, the kernicterus is going to be rare compared to what we saw in type 1, which was the most severe form. Now, interestingly, there is a medication treatment here for type 2, which is pretty high yield to know for the STEP exam, and that's phenobarbital. So phenobarbital is a barbiturate that has been used for a variety of different things, including seizures, and that's because it's a depressant of the central nervous system. But one of the things that they found was an interesting side effect of this medication is that it increases the activity of the UGT enzyme. So it can actually be useful in these patients with type 2 who are right kind of on the borderline of developing severe symptoms. It can actually upregulate their UGT activity, and therefore it can be used for a treatment for type 2 Crigler-Najjar. It's the only one of the conditions we're going to learn about today where phenobarbital is a treatment, so it's important to know that one. Now, phenobarbital can't be used for type 1 because basically here you have completely absent UGT activity, so there's nothing to rev up. Therefore, it's not going to be useful for type 1, and you wouldn't use it for Gilbert syndrome because in Gilbert syndrome, the hyperbilirubinemia was so mild and transient that this type of treatment was not necessary. Therefore, phenobarbital is important and helpful as a treatment for type 2 Crigler-Najjar only. All right, so now let's check back in with our diagnostic algorithm of jaundice. We've already covered Gilbert and Crigler-Najjar. Now we're going to end the video by talking about the two conditions that lead to rise in direct bilirubin, Dubin-Johnson and Rotor. All right, so let's start with Dubin-Johnson, and in order to explain this, let's take a look at our figure again. So here we've had unconjugated bilirubin entering from circulation into the liver. It gets conjugated via UGT, so no problem here. We're making plenty of conjugated bilirubin because UGT is not the problem here. However, once you make this conjugated bilirubin, it has to then be eliminated from the liver cell by getting dumped into bile. So it has to be transported from the hepatocytes, which is the liver cells, into the bile canaliculi, which are the small channels of the bile duct, and then eventually it gets transported into the rest of the bile ducts and enters the small intestines to be eliminated. The problem in the Dubin-Johnson disease is that you have a defect in this transporter protein MRP2 that's important for exporting this conjugated bilirubin from the hepatocyte into the bile canals. So therefore, you're going to have decreased excretion of conjugated bilirubin from the hepatocytes into the bile canals. So this is going to lead to backup of direct bilirubin. So you're going to have high levels of direct bilirubin. Now, the symptoms here are going to be mild, and generally no treatment is required because usually this defect is mild. And one important kind of high yield feature that's associated with this condition is on histopathology of the liver. So on gross pathology, you're going to see a dark black liver, and that's because on histology, there are actually granular pigments that have this epinephrine metabolites that's kind of like melanin. Therefore, it gives us this dark or granular appearance. And this is a very high yield feature of Dubin-Johnson, and this is how you're going to be able to distinguish it from Rotor syndrome. So now let's talk about Rotor syndrome. So this is very similar. Again, you have a defect in this time mostly in the hepatocyte storage of conjugated bilirubin. There's no specific enzyme or protein that you need to know here. Just know that the main problem is a defect in storage of conjugated bilirubin within hepatocytes. So they end up leaking into blood and lead to high levels of direct bilirubin. The clinical features are going to be similar to Dubin-Johnson, and they're going to be benign, and generally no treatment is going to be required here. Again, one main distinguishing feature between the two of these, so say you have a patient on a test question that you're suspecting has hereditary hyperbilirubinemia. Most of the bilirubin is direct, so you've narrowed it down to these two. The key way to distinguish it is that there's not going to be any hepatocyte pigmentation or blackened liver in Rotor syndrome. All right, and so here's our summary table. We have the top 3 rows, which are in the pink, and these are the ones that primarily cause high levels of indirect bilirubin. So our first one was Gilbert syndrome. So you have a mild deficiency of the UGT enzyme, and the symptoms are going to be primarily transient related to stress, no specific treatment. Then you have Crigler-Najjar, which is either type 1 or type 2. In type 1, there's essentially no UGT activity, so this is severe, and this can cause kernicterus and severe symptoms throughout life. Main treatment here is going to be a liver transplant, whereas Crigler-Najjar type 2, here the symptoms are more mild to moderate, so presentation is going to be typically mild, and this is the one where you can use phenobarbital to rev up the activity of the remaining UGT enzyme. And the bottom 2 rows that are shaded in blue, these are the ones where you're going to primarily get high levels of direct bilirubin. So the problem here in Dubin-Johnson is you have impaired conjugated bilirubin excretion because of the defect in this exporter protein MRP2. The symptoms here are going to be mild, no specific treatment. The key feature here is going to be the dark liver due to the pigmented granules. And in Rotor syndrome, the main issue is impaired conjugated bilirubin storage within the hepatocytes. Similar clinical presentation to Dubin-Johnson, except no darkened liver and no granules. All of these are autosomal recessive, and all of these are going to present with primarily elevated bilirubin, for the most part without significant elevation in other LFTs. Okay, that's it and that's all. If you want to learn more about this topic, you can check out the other videos that I've linked here. And if you guys enjoyed this video, don't forget to like, comment, and share it with others. And also consider subscribing to this channel so you don't miss out on any upcoming content. But for now, thank you for watching, and I'll see you next time.